then. And then use selective serotonin reuptake inhibitors, SSRs, and other persons that affect serotonin levels.
Okay, did y'all hear that?
No.
I want y'all to stand up when y'all talk, because see, it kind of, those folks kind of block my hearing.
I'll start over.
Can you stand up? Your voice carries up here, not down there.
Fibromyalgia is characterized by muscle and connective tissue pain. It's controversial diagnosis. Why is that? You know why that is? Because it's hard to.
Because they really don't
There's no
know.
testing for
I don't
it.
know if it's true.
Yeah.
They try to think a lot of these people are just faking it. And that's why a lot of people that have it get very upset about it, because they have true pain and they can't find out why. But they got tests now with trigger points and things like that they can do, and that's helping them to diagnose it better.
All right, the signs and symptoms are chronic pain, generalized muscle deconditioning, and decline. And they usually go with insects and with trying to support group, and they do like aerobic exercises, swimming. And they use selective serotonin reuptake inhibitors, antidepressants that affect serotonin levels in the brain.
Okay. All right. We're getting the clap for all these folks. That's hard work y'all do. Okay.
Clap all for everybody at the end.
Yeah, we can do that.
That way we can remember.
All right. Come on now, as long as y'all listening, you're gonna be all right. Okay, let's talk about fibromyalgia, just to kind of summarize that a little bit. Like she said, it's controversial because for a long time they thought people was just pretending. They really wasn't hurting like they said they were hurting, because they couldn't find a real reason for them to hurt. But like I say, nowadays they're doing the trigger points and things. The book speaks to you about that, about how they can, tell about where people's pains are coming from and how they connect in those nerve endings. You mentioned several things that's important to know about fibromyalgia. One, these people get very fatigued, okay? And one of the main things that as nurses we need to make sure is that these folks get their rest. They sleep uninterrupted at night. We don't go in and wake them up every couple hours. We try to arrange that we give their medications at a certain time so they get an extended period of sleep and rest, and we teach them to do that at home. We also teach them that, they don't need to be drinking a lot of caffeinated drinks and things like that that might interfere with their sleep at night. We teach them about a lot of them have depression because they don't know why they hurt. They don't have a whole lot that they give them to keep them from hurting sometimes. So they live with some pain that they can't control, and it's all the time. And so they take these SSRIs, which are these antidepressant type drugs, and what we have to tell them is that they take them at night. Don't take them in the morning so they have to sleep all day. They can't sleep at night, okay? So they need to take those at night. The other thing is, because they're so fatigued and all, and they need their rest, and we see that they get their rest, the other big thing with the fibromyalgia is that they need to stay as active as possible. You don't use it, you lose it, right? Mm-hmm. And so these people need to stay as active as they can, and they have to do exercises that they can do without hurting themselves. And what kind of exercises did your book talk about?
Aerobics and
Swimming, low impact type aerobic, type swimming exercises that will keep them mobile, but yet it won't damage them, okay? So making sure they get plenty of rest and sleep, making sure they stay active, okay? Those are two important keys to me as it relates to fibromyalgia. I'm trying to think if there's anything else sticks out in my mind. I don't remember everything. I'm just saying, things that stick out. We talked about, being careful about doing things like doing something that'll keep them away. You don't wanna give them caffeine and all that kind of stuff, too late a meal, all those things. Okay, moving right along. How about rheumatoid arthritis, number 13?
Okay, we have rheumatoid arthritis as a chronic progressive inflammation and degeneration of connective tissue, which is usually in the synovial joints. The signs and symptoms are joint pain, swelling, stiffness, warmth, and it begins in smaller joints and then it progresses to larger joints. And also there's weight loss, fever, fatigue, and Raynaud's phenomenon. And then a diagnostic test, anti-CCP, x-rays, and then there's labs for the rheumatoid factor, ESR, and C-reactive protein. And for treatment, we have NSAIDs, COX-2 inhibitors, methotrexate, opioids, corticosteroids, cyclosporin, and then for surgery, joint replacement surgery. And then for nursing, we're going to have a balance of rest and exercise, physical therapy, occupational therapy, ice and heat for the joints, reduce stress, and then also encourage them not to mobilize the joints.
Not to what?
Immobilize the joints.
Okay, so keep them moving? Okay. All right, so you said a lot of things that, and somebody earlier today talked about, well, she suggested we wait to the end. So we'll wait, we'll clap for everybody at the end. Don't any of y'all that's coming up feel left out though, okay? We're gonna do it. She mentioned earlier today about the paraffin wax on the therapeutic devices, I believe, when we were talking about that. Making sure that, you know, people like with rheumatoid arthritis especially, we talked about handling those utensils. You know, the occupational therapist can see them about making sure they have some utensils to help them with their deformities as far as eating, to keep them mobile, to keep them active as much as they can be. People with rheumatoid arthritis, they get up in the morning and they're usually really stiff, right? And it takes them a little while to get moving. And that's why, you know, the warm showers in the morning is helpful to these folks. And also the paraffin wax for their hands. They're going to be doing something with their hands. So methotrexate, you mentioned, that's the gold standard, I think, for the treatment of rheumatoid arthritis. That's also used as a cancer drug. They have nodules, okay, and herpes, I think is what it is, nodules that they can have as a result of rheumatoid arthritis. Look at those in your book. Those pictures of those nodules versus what the deformity looks like. Y'all see those pictures. I don't use PowerPoints a lot, but there are some pictures that you need to really look at, and those would be two. Look at those, how the joints look, okay? Let me think, what else you said? Keeping them active is very important. People with rheumatoid arthritis, just like with lupus and other of these autoimmune disorders, they have flare-ups or exacerbations, and they have hot joints, okay? Now, there are medications that they can give for, like DMARDs. Y'all need to kind of look at those disease-modifying, whatever, drugs, okay? And NSAIDs and things like that they may feel for inflammation. But what do you give for osteoarthritis? What drug? There you go. But for these, you liable to have to give an NSAID or a DMARD or something like that. It's different. It's inflammation, whereas osteoarthritis is a chronic, not necessarily inflammation, right? Okay, so just understand the difference there. Let me think about what else we'll talk about with rheumatoid. Something you said. I can't see that far, so I'm having a hard time trying to remember what you said.
I'm with you, sister.
The activity is the main thing, I think, you know, is that you stay mobile, like he said. But you mentioned, I know what it was you said, you talked about using the small joints that affects the big joints. It goes from, okay. Yeah, it starts with the small ones, then it progresses on to the larger ones. Okay. What else might be important for the rheumatoid? Okay, y'all know it's an autoimmune disorder that attacks that synovial fluid in the joints. And that's what's causing this. Necrosis and the damage to the joints. That's the autoimmune type problem. So you might want to just kind of review that just so you'll understand how that process is happening to these folks. I just don't remember anything right off. I don't want to forget anything to tell y'all, but I just don't see anything else that you really need to know about that.
So the main thing with those patients is like NSAIDs for pain and then just keeping them active so they don't stiffen up.
And DMARDs, you might want to look up those, the DMARDs. But on your sheet, it didn't give me DMARDs on your thing, so that's why I didn't concentrate too much on that. But I think you just need to think about it, whenever you're thinking about rheumatoid and the joints, the debilitation of the joint, how you're going to help this person get up in the morning and have a good day, okay? Keeping them active as possible, but not straining those joints. Because if you do too much, what's that going to do? That's going to be the opposite effect, but you got to make sure that balance is there. Keeping them active, but yet doing it sensibly. Okay, moving right along, let's go to gout. Number 14.
We had gout. It's a systematic disease in which uric crystals deposit in the joints and other body tissues causing inflammation. It's most common acute inflammatory arthritis in older adults. It shows up as like severe pain, redness, and swelling in the joints, most often in the toes, the big toe. It's sudden onset, and it happens more at night because they're still, so it can't move. Also causes physical deformities and affected joints. Same concept as like arthritis, it just swells. There's also where crystals, like, it's really weird. It looks like little like pustules show up on the skin. Makes you want to pop them. So the biggest thing with gout is like their diet. So low purine diet, which pretty much it's like no meat for the most part. Like seafood, very limited, like shell, like very minute shellfish. So like crab and shrimp you can eat with it. It's low in purine. It was mainly meat that I kept reading in fruit. I mean, in like certain vegetables that you can't eat, but all the bad stuff you can eat with it actually. Like eggs, nuts, peanut butter, low-fat cheese and ice cream, skim milk, fruit juice, a lot of different grains and meat products. You can still eat sugar and sweets and jello, have oil and heart healthy fats. It said you can have meat, but it's like 4 to 6 ounces, and it's only like poultry. That's not a lot of chicken for a daily course of food. So I guess that peanut butter, you have to give you your protein. Also, you would check for like labs. A lot of the times they do a synovial fluid aspiration where they just go into the joint and aspirate some of the fluid and test the fluid to see if it's high in uric acid. They also can draw uric acid. Sometimes if the crystals are present, like there was one picture we saw, it looked really infected, like the crystals were busted open, so it was like almost like her whole entire fingernail was like almost completely covered by swelling and pustule crystal pocket things. So you would like inspect those areas. There's medicines that you can get prescribed, like albuterol, which is and like it decreases the uric acid production. It also helps excrete the extra uric acid. Lifestyle change is a big thing. Aspirin can mess with it more. A big thing that it like stressed about was also like stress management techniques and increasing your fluids.
Right. That's good.
Cool.
All right. Okay, let me give you a proof of that, okay? All right. First of all, what happens in gout, as they said, is a buildup of the uric acid crystals, okay? And as a result of those crystals that build up, one of the things that it does is it can cause kidney stones.
That's why it said that, we kind of ran out of room.
Okay.
That's the reason why it said increase the fluids, because of the buildup of the crystals that it can lead to kidney stones in it. I just forgot that part, so you said it.
Okay, good. I filled in something, huh?
Yeah.
Okay. Well, see, that's the main thing, is you understand that gout is a result of too much uric acid, okay? And as a result of that, it can cause kidney stones. It can cause it to build up in these joints. And the big toe is one of the areas that it builds up a lot in, and it becomes very inflamed. Now, when you get to level 3, instead of us doing all of this, we may add a YouTube video, all right? Because I love YouTube. Now, in the past, one of the YouTubes that I watched that was one of my favorites was where it showed gout in the heels. And it showed where all of this pus and stuff was coming out of a person's heel. They were expressing that all out, you know. And it just showed the significance of what can happen when that uric acid builds up in these joints and causes infection and inflammation. And I don't know if anybody in here's ever had an episode of gout. Anybody?
Witnessed it, but never had it.
Well, you'd know it if you had it. Because I've seen it a lot of times. My son, matter of fact, has had it.
It like swells up and like calcifies into like hard nodules.
Well, when it inflames, like if you just are having it for, just a flare up of it, that toe gets really big, swells
red.
up, it's red, okay? And excruciating pain. Excruciating. You can't walk, you can't even hardly talk because it's so painful. So if you ever have somebody that has gout, then you need to really pay attention.
Can it work the other way around? If they have a history of the uric acid kidney stones and then they get the gout?
I suppose. You know what I'm saying? Because my son had stones and gout. on
My
his
husband
toes.
does too, that's why I asked.
Yeah.
The gout was after the fact.
All right, but what you need to remember, some people's having private conversations in here, and if you don't do well on the test, don't blame me. Okay, this is the thing. With the gout, one thing you need to remember is fluids. If you've got all these uric crystals in your kidneys, and that allows them to sit there, then they're going to form stones. Okay? So you've got to make sure that these folks drink lots of water. They do not need to drink alcohol. Do you understand why? Why?
Because of the acid in it.
The reason they don't need to be drinking this alcohol, like hard liquors and such, is because it dehydrates. And if you dehydrate, you're defeating your purpose there too, right? No alcohol, really. Should not be drinking a lot of alcohol, period. But anyway, for that reason. So they need to drink plenty of fluids, not so much alcohol, okay? And I have seen the difference in stones, uric acid stones versus calcium stones, okay? Calcium, you know, a calcium stone. I had a calcium stone, 10 millimeter calcium stone. And it was slick, just slick as it can be, white, slick looking, okay, brownish color. Uric acid stones, I saw my son, and they have little barbs on them. They have, it's like a little round circle with little barbs, okay? And when that's coming down the ureters, it's tearing, it's cut. The calcium stone hurts, but it's slicker. You see what I'm saying? So when people pass these uric acid stones, it can be a little tiny bar thing, but you talk about painful. If y'all have ever seen anybody have a kidney stone, been around it, just appreciate the fact You know, gout
Oh,
is
there's
very
the stents.
painful, so is kidney stones. All right? So I just want to mention that. But stress will cause an attack sometimes. Alcohol, and you mentioned aspirin back there?
Yes.
Okay, aspirin can cause an attack for some reason. Okay? So, those are three things I just want to make mention to kind of follow up with what y'all said. Colchicine, you mentioned, was one of the medications that they use to decrease the amount of uric acid in a person's blood, so it decreases, the amount of uric acid in the joints. Huh?
The name of the drug?
Colchicine. Colchicine, maybe? Colchicine. And they do give a med called Probenecid, and they'll give that for a chronic condition, where the colchicine they may give to, just like during a flare-up or something.
Can you spell that?
Probenecid? Yeah, I don't know. Probenecid. Thank you.
So I'm confused on like the stuff in the big toe. Is that like, is that the crystals
Yeah.
traveling from your kidneys?
No, it's in the blood.
Or-
It's in the blood.
It's just depositing in that joint.
Uric
Just like it
acid,
deposits in your
uric
kidneys.
acid is in the blood, and it
Okay.
forms crystals in joints and in kidneys and in places.
Okay.
Okay. All right. So sometimes people, though, another drug, I'm just going to mention this now. I'm not that y'all have to remember all this, but I just need to mention it because next semester you're going to need to know it. Alpurinol. That's another one that they give to folks that have kidney problems to treat gout. Okay? Yep. So I'm just mentioning drugs, and you may hear it in excretion in other places. I don't know. But anyway, so guys, we talked about limiting stress, limiting alcohol. Also, what else did I say? Oh, purine foods.
Yeah.
Okay. Now, what is the purine foods? And they may mention most of it. The things that are high in purines are the organ meats. Okay? What would that be? Liver. Gizzard.
Tongue.
Okay.
Some people eat it.
All right. I mean, just think about the organ meats and stuff, okay? All right. That's enough on gout, I think. Just remember fluids. Remember your low purine diet. Okay? Don't limit fluids, please, other than alcohol. All right. The next one we got to move on is scleroderma 15. Who's got scleroderma? Number 15.
It's an inflammatory response which causes unwanted skin changes, but the cause is unknown. Signs and symptoms are edema, tight skin, loss of elasticity. The esophagus becomes hard and rigid. Patients become stiff and lose mobility in the affected extremities. The tint of the skin has a tightness and hardening, which is caused by the swelling. You want to assess your patient for changes in increased blood pressure and urine output, because these are signs of impending organ failure. Your treatment is exercise and physical therapy to prevent contractures. You need to provide your patient with skin care and teach your patient to avoid cold weather. Your meds are going to be calcium channel blockers and anti-inflammatory medications. And the outcome can be major organ damage is likely to develop if it goes untreated, and possible loss of digits due to poor circulation.
Okay. All right. And did you talk about the crest?
Yes, ma'am, that's in the signs and symptoms.
Okay. And now scleroderma, like I say, all these are autoimmune disorders. Your body's fighting itself, okay? And like she was talking about, a picture paints 1,000 words on that one too. Like the butterfly rash you see with SLE, but then with this scleroderma, this lady, you can see, I think it's in your book where she has that real tightened skin, shows a picture of them. And so you need to just kind of get in your mind what that looks like so you can associate signs and symptoms with that. And when it has this hardening or this fibrosis that happens as a result, where the esophagus and all starts to really get fibrous. These folks can't swallow as easily, so that puts them more at risk for aspiration. And so we have to be very careful about making sure that we give them things that are easy to swallow, make sure they're sitting up when they eat, make sure we have stuff at the bedside, you know, suctions and things like we do with myasthenia gravis. You know, we make sure that we have things that, you know, life-saving things in case they choke as a result of this. And she also mentioned about how these people, they get Raynaud's phenomenon, and y'all know what that is, where the blood vessels constrict and they get those cold fingers, okay? And one thing you need to know about the scleroderma is that they don't need to be in the cold, and if they go out into the winter weather or whatever, they need to wear mittens and make sure they're covered well, okay? Because that would not be good. There are people who have had scleroderma, and let me see, I'm trying to remember the term that we used. They're dactyly, what's that word? Y'all got that in front of you? What is it?
He said pterodactyl.
Not pterodactyl. But it's where they lose the fingertips. They'll fall off. Their fingertips will fall off. And people do, that happens to these people.
Because things are hardening, correct?
Yes, they're hardening and the
My aunt had
circulation's
it.
not there, and they have that Raynaud's phenomenon, okay? So that's what's important about that, okay? I'm trying to think of things that I think you need to know. Another name for scleroderma, and sometimes people get this confused, is systemic sclerosis. That's another name.
So is it like multiple sclerosis?
Yes, ma'am?
I went to high school with a girl who had scleroderma, but it didn't show up until she was in her early 20s. She passed away last year from complications of it, respiratory depression. But her fingers fell off too.
Okay.
She was a local artist down here.
Really?
Yeah.
Yeah, she would paint without her fingertips.
So see, it is real, guys. And see, when people like that understand and they have seen it, it makes more sense. Okay, I can sit here and talk to you about it, but until you actually see a person with it, you know, it's hard to visualize that. Okay, but thank you for sharing that. All right, well, y'all just look at that scleroderma, look at it from the perspective that these people really need high protein diets as well. They need to eat frequent, smaller meals, okay, because of their swallowing. And just remember the Raynaud's phenomenon with this one, and the fact that they could lose their fingers, tips, okay? And they, like, she was very young, and she died young. And she was about
29.
29. So that's why I'm trying to tell y'all, these are serious things, and it happens to people. And you'll be taking care of some of these folks. All right, the next one is HIV/AIDS. We're running out of time. Okay, who's got that?
We have that HIV/AIDS. Basically, it's the damaging of the cell and immune system. The labs that we're going to look for is like the platelets and the CBC, if they're lower than the normal range. HIV/AIDS is transmitted through maternal sex, bodily fluids, and blood. Once upon a time, they thought that you can contact HIV/AIDS with saliva, but that's not the case now. We will have the patient on standard precautions. One of the tests that we will perform will be the EIA test. This first confirms HIV infection. And then the second test we will perform is the Western blot. If EIA is positive, then this test confirms if the patient has HIV or HIV/AIDS. The patient can have the virus for 6 months to a year but still test negative. So we want to teach the patient if they haven't had an encounter with somebody who has HIV/AIDS to keep getting tested throughout the year. The signs and symptoms is chills, rash, anorexia, weight loss, headache, nausea, flu-like symptoms. The diet that we will teach the patient is high protein, low calorie, no raw fruits, meat, or veggies. We're also going to teach the patient to avoid crowds, don't share personal items like the toothbrush, anything else that's personal to them. Replace toothbrush weekly. Report high temperatures, coughing, and drainage. Report cloudy urine signs, which is signs of infection, and wear condoms when having sex.
There you go. What's the number one way to prevent AIDS?
Save yourself.
Abstinence. Don't have sex.
No saying abstinence, right?
Yes.
But then if you're going to.
Make sure they don't have it.
Wrap it up.
Don't be silly.
Condoms, right? Okay, let's recoup on that. We only have a few minutes. We've got a couple of drugs we got to talk about and organ transplants. Okay. Y'all, you really need to pay attention to HIV/AIDS and know about your labs. What we talked about, when you get a less than 200 CD4 count, that's when they're going to diagnose the person with AIDS. They are usually going to have an opportunistic infection that goes along with that, and some common ones would be like candidiasis, or the thrush in the mouth, or the PCP, which is the pneumonia. Okay, that's common that some people have, and that's when a lot of times they have a lot of these opportunistic infections, but they don't know it. Okay, but nonetheless, when that CD4 count gets less than 200, they're going to get that diagnosis of AIDS, and most of the time they do have opportunistic infections with it. She mentioned about making sure that these folks get a high-calorie, high-protein diet, because a lot of them have wasting syndromes and things like that, and they need that calories, they need that protein.
Wait, say that again?
Huh?
Say that again?
Say what again?
High. Because you said high calorie and we have low calorie up here.
No, it should be high-calorie.
Should be high calorie.
Lose some weight.
Okay, so they have low calorie, so that's wrong. Okay.
Yeah, you need high calories, you need a lot of calories, and
It's
then you
okay.
need protein.
She'll make sure we had it right.
All right. And, now, we talked about transmission and ways to prevent that, and, let's see what else I want to talk about. Standard precaution. You know, just because a person has HIV doesn't mean that you can't touch their hands, right? We talked about that. But remember too, with these folks, there's always been some sort of social stigma attached to having HIV or AIDS, and a lot of people don't want to go near them. And I mean, I can tell you stories about myself when they were first, had the first HIV cases in Jackson County. I took care of some of them. And we were dressed from head to toe, that's what was vision. I could see, you know, very little bit, because we was afraid what we was going to touch, okay? But there again, as time went on and we learned more about it, we realized you could touch somebody, okay? But there again, when we're talking body fluids, that's a different situation, right? But what my point of this is, it doesn't make any difference what type condition a person has, standard precaution with everybody, okay? Everybody, standard precautions. But if you know you're going to be touching body fluids, then you have to protect yourself accordingly. Right? Okay. The next person that's going to talk to us is going to be talking about organ transplants. 17, number 17 first.
There's 3 types of rejections with organ transplant, and it's hyperacute. With hyperacute, it occurs within minutes of the transplant. Acute rejection, usually within the first 3 months, and chronic occurs after months or years of normal function. So signs and symptoms of this would be graft rejection, reaction, graft versus host disease, serious infection, and adverse effects. Nursing interventions would be isolation procedures, hand washing, nutritional intake, monitor their lab values, and immunosuppressive drugs.
Okay. All right, that's fine.
Okay.
With the organ transplants, I guess this is introducing you all to those. What I think the take home from this is, like she mentioned, there's 3 types of rejection. Y'all need to review those so you'll be familiar with them. Like the hyperacute, that happens immediately. They take the organ out within a short period of time of putting it in. And then with the acute, a couple things about that. One is it can happen like a week later, 3 months later. Okay, and it can happen periodically. Try to reject that organ periodically. However, just because you have a reaction doesn't mean you're going to lose that organ with the acute. Okay? So adjusting their drugs and stuff have saved a lot of organs, in other words. All right? Because they're going to be on those anti-rejection drugs for life. And they have to be adjusted because you don't want to get somebody too immunocompromised because they'll get a bad infection of some sort. Okay? But yet you got to keep them to the point where their body won't reject their organ. So it's a fine line right there. Okay, and chronic, like she said, is something that can happen even years down the road. And what you have to do though is if, like the very first, like if you have a hyperacute, that organ's got to be taken out and replaced. With the acute, it may or may not, depending on whether it can be managed through drugs. The chronic, that's later on down the road. And at some point, it may become so fibrous that it has to be replaced. And that has to do with the blood supply, guys. When you think about organ transplants, these acute problems, the hyperacute, acute, and chronic, all has to do with how that blood supply supplies that organ. Okay? So that's what I need you to just kind of think about there. All right, number 18 is corticosteroids.
Oh, that's last. Okay, so when you use corticosteroids, you're going to be treating a patient that has HIV, organ transplants, or rheumatoid arthritis, because the goal is to reduce the inflammation. Some side effects that you might have would be an increased heart rate. It'll increase your blood sugar. It'll increase your sodium. It will decrease your immune system and your white blood cells. You will have weight gain, and you will have decreased wound healing because you'll have the decrease in white blood cells. So as a nurse, you would want to report vision changes. You would want to possibly do an EKG. You'll assess their vital signs, their blood pressure, their intake and output to monitor their weight. And you would want to do a TB skin test because you want to make sure they don't have TB before you put them on a steroid. And so you want to teach your patient not to stop them abruptly. You want to taper it down. We talked about that. Avoid large crowds for infection because you're immunocompromised. You want to have daily weights to monitor your weight gain. You want to take it in the morning with a food or milk. And you want to keep your follow-up for your labs. Your diet would be a low-sodium diet. And you want to increase your vitamin D, your protein, and your potassium.
All right, well, I think y'all are going to have those corticosteroids for a long time in this program. So get familiar with them, okay? Take a good snapshot of that one. Okay, who has antihistamines?
We do.
Okay, go ahead.
Antihistamines are used for allergies. They're used to prevent and relieve the symptoms related to allergic reactions. In the elderly, the elderly are more sensitive to the effects of the antihistamines. There's some side effects they have is confusion, painful or difficulty urinating, and also with pregnant women, that antihistamine should be avoided, especially for the first few months, because it can cause birth defects and stuff like that. Drug interactions while taking antihistamines. They had like a whole a big old list full of meds, but I just wrote a few. We just wrote a few up there. It's alfuzosin, chlorpromazine, famotidine, fingolimod, and a lot of others. And it also said that you do not want to consume grapefruit juice while on the antihistamines.
Okay.
Nursing interventions is to teach the patient to take with food or a glass of water or milk to decrease GI irritation. And one of the meds, or it said one of the original meds was diphenhydramine or Benadryl.
That's right.
And a side effect of that is drowsiness.
Okay.
And I know you asked us about the prophylactic antihistamines too. One of the things that I found is that you can take an antihistamine 2 to 4 weeks prior to pollen season, and that would help people, like, I guess, cope with their allergy flare-ups and stuff like that.
Okay.
That's
All right,
all.
they may give something for a blood transfusion too, if they suspect somebody might have a reaction to, a blood transfusion, prophylactic. All right, one of the things, and I guess I just need to kind of go back in and think about with the antihistamines and thing. I think about, when people are like, we didn't talk a lot about this when we were talking about giving allergy shots and things like that, and testing people for allergies with the hypersensitivities and things like that when we were talking. One of the things about corticosteroids, and I'll just make mention of that too, if somebody's taking corticosteroids for hypersensitive issues, but then they go in to have a test to check for their sensitivities, they got to be off those steroids.
Mm-hmm.
You know what I'm saying? So I just wanted to bring that in as far as the steroids are concerned. But yeah, Benadryl probably is one of the more common antihistamines. But then, of course, they have others, chlorotrimazole, all those different ones. But just know what the antihistamines are and what they do, okay? And if you recognize one of them. The other thing on here, and I know y'all ready for lunch. Everybody's getting hungry and tired of talking, right? Okay. I want to tell you about the antiretroviral drugs. I'm not going to ask you to memorize any of those drugs this time. I'm going to just tell you that right off the bat. You don't have to worry about it. Okay? I want you to know what they are, though. And I want you to know what they do. Why do people with HIV, AIDS, take antiretroviral drugs?
To keep their platelets, I guess, not platelets, white blood cells, at the same level so that they don't decrease.
Okay. All right. Let me tell y'all something. The two goals that you need to remember about HIV/AIDS. You want to increase the CD4 count. The higher that CD4 count is, the better that person's going to be. Their outcomes will be better. And you want to decrease the viral load, amount of virus in the blood. Increase CD4, decrease the viral load. And how do we do that? We do that through the antiretroviral drugs. Okay? We're trying to decrease and prevent the replication of the HIV virus in the blood.
So it's turning into AIDS.
Well, HIV, see, when a person gets infected with the HIV virus, there is a picture in your book, and I'm sorry, I don't have it, but I wish I did. But there's a picture that shows the normal cell, and it shows where these drugs will take and stop the replication of that virus from taking over that cell, which is a CD4 cell. Okay?
So it kind of protects it.
Huh?
It protects it from
Well-
getting damaged.
What it does is you've got like fusion inhibitors. Okay? You've got about 5 classifications of these drugs. All right? And like the fusion inhibitor is going to keep that virus from connecting to the cell, to the CD4 cell. So it stops it at that point. Okay? And if you read on about how the HIV virus gets into that cell, it has to change that cell's DNA. And there are drugs called NRTIs and NNRTIs that will stop that from changing. It will trick it so it can't change it and become a virus. cells. Then you have some of these cells, there's another enzyme that's called protease in there. And you have some drugs that were created to stop that process from happening. My point of this is that in third level, we're going to talk more about these drugs, and we're going to talk more about how they stop the replication of the virus. But right now, I just want you to take a look at that picture in your book. Look at where all those different drugs stops that replication. Okay? And that's what I want you to know right now, is that they have developed 5 or 6 different types of classifications of antiretroviral drugs that will stop the replication of that virus by not allowing that virus to take over the CD4 cell count. Okay? And it will therefore increase the amount of CD4 cells the person has. And that's one of the outcomes, right? That we want. Increase that CD4 count. Okay, the other thing, you know, the cells, like I say, once they are infected, you know, that's what will increase that viral load. You see what I'm saying? So our 2 goals, if you can keep that in mind, is to increase the CD4 count by preventing that virus from taking over any more of those cells than it has, and therefore we will decrease the viral load in the blood. And people should, if they are put on medications, and we mentioned like below 350 is when they start looking at putting people on meds. The other thing about that is they don't ever do monotherapy for HIV. They always give them a combination of drugs to treat HIV. Not just one drug, because people can become resistant to that one drug and allow the replication to be more. Does that make sense? Mm-hmm. That's where I want you to know with the antiretroviral drugs. Okay? Okay. All right, guys. Hey, listen, the S&O, we're trying to get that put in.